Good afternoon. My name is John Batenhorst, EMS Captain and Training Officer with Johnson County Medac. Today we're going to discuss the controversy of pre-hospital endotracheal intubation. In doing my research for this presentation, I found the controversy of intubation is a pretty broad topic. There are several things here that I could discuss, including the blade type and size. Other things could be the light bulb that people prefer in the blade, and even what type of technique they use for their intubation. I thought those topics may bore you, so we'll talk about the idea of intubation and some statistics that I found here at Medac in the last year. So some objectives I have are the evaluation of the endotracheal intubation as the primary means of pre-hospital ventilation. We'll discuss paramedics' ability to be proficient, and we'll define proficiency in pre-hospital intubation. We're going to examine some benchmarks for pre-hospital endotracheal proficiency. I'll also compare differences between a technician and a clinician. Lastly, we'll discuss Eureka point for psychomotor skill competency, and again talk about our statistics here at Johnson County. So we'll start with the gold standard. The gold standard, as you can see, is defined as the best, most reliable, most prestigious thing of its type. So is the endotracheal tube still the gold standard for pre-hospital care? I think that depends on who you ask and what type of experience level that person has as far as the gold standard being the endotracheal tube. So is it yes, no, maybe, could be any of those. Paramedics have graduated with the idea that failure to intubate was substandard care. In reality, failure to ventilate a patient is substandard care, not necessarily a failure to place an endotracheal tube. We have several ways to achieve ventilation, including simple airway opening maneuvers. So, are we good at intubation? Pre-hospital endotracheal intubation often requires multiple attempts. As you can see in this slide, there's several examples of studies that were done with real case studies of pre-hospital intubation. On the left, you'll see in 1,941 cases of pre-hospital intubation, over 30% of the patients required more than one attempt. So that brings up the question at the top, are we good at intubation? Some other examples on the right, you'll see the cumulative success rate overall per attempt for 3 attempts. Some of them are under 70% cumulative success rate. And then lastly, the non-arrest success rates. Some of those are the most difficult airways we see. And again, those numbers are pretty low. So proficiency, have we ever been proficient? Here you'll see there's several other studies that were done of pre-hospital intubations. An example is Jenkins' study at the top shows that 2 misplaced intubations out of 39 attempts. That's an over 5% unsuccessful rate. If you go down to Stewart's study, in 779 intubation attempts, there's 3 misplaced tubes. So that's less than 1% of unsuccessful intubations. So what this tells me is the more we do it, the more we practice, the better we become. So how do we achieve proficiency? It appears that practice makes perfect. So how do we define proficient? Who's the judge? Who's the comparator? And will we ever get there? So who's the judge? Is it the medical community as a whole? Is it our peers? Is it the physicians we see? Is it our QA process? Is it our management? Who's the judge to say whether we are proficient at intubation? Or ultimately, is it our medical director? Who's the comparator? Who's good at this? Who is proficient? Some examples are the anesthesia departments. They do intubations every day, all day. So is that who we compare ourselves to? Or do we compare ourselves to other EMS agencies or even other emergency services such as the emergency physician that we'll be transferring our patient to? Will we ever get there? Way back when I went to school, the internship required 5 live intubations. That doesn't seem like very many, especially when we are compared to the CRNAs and anesthesia who do over 400 intubations in their internships. I would say that answers most of those questions of who's the judge, who's the comparator, and how do we get there. And what do we strive to be? Are we a technician or are we a clinician? Are we simply there to do the skill, or are we using the skill as a means of ventilation, not necessarily intubation? So one way to get there is something called the Eureka point. The Eureka point is a concept that was introduced to EMS education back in '95 by somebody that many of you know. Kim Grubbs from Johnson County Community College presented this concept at the EMS Today conference in '95. So you ask, what is the Eureka point? You can think of the Eureka point as the aha moment. For intubation, studies have shown that the aha moment, or the Eureka point, happens at 19 consecutive intubations without a failure. So in order to achieve complete proficiency, one must successfully intubate 19 patients in a row without a failure. Even John Linville would be proud of those numbers. So has this ever been done in Johnson County? I'm not sure. Without pulling all the data, there's no way to tell if anybody has ever got 19 consecutive intubations without a miss. So another way to define the Eureka moment, an example is IV success rates. This was part of the study that was introduced in '95 by Kim Grubbs at the EMS Today conference. He used IV skills to discuss the Eureka moment. This graph shows one of his studies of a student who did multiple IV attempts from August of '97 through June of '98. You can see they had 49 attempts and they achieved the Eureka point at 29 attempts. The red line indicates there are fewer than 10 attempts and the success rate is less than 60%. The yellow line you can see on the graph indicates that the success rate is between 60 and 80% with at least 10 attempts. And the green area indicates the success rate is above 80% in the last 10 attempts. So between 19 and 29 attempts at an IV, the student achieved the Eureka point and continued to be near that line for the rest of that study. I did find this to be true in my own experience as well. When I first started here at MedAct, I was fresh out of school and didn't have much experience with IVs or intubations. After working here for a few years, my IV success rates were at the norm for the department. After obtaining a part-time job where I did blood draws on the side, anywhere from 20 to 100 blood draws in a day, my IV success rates significantly improved. So it just goes to show that I reached the Eureka point by accident doing my blood draws on the side, which improved my IV skills. Here you'll see the 2017 Johnson County Airway statistics. This slide is pretty busy with lots of information. If you look over on the right side, you can see the total intubation attempts. The first line attempt is at the top, and the second attempt device is on the bottom. If you look in the upper right-hand corner, it appears that we attempted 8 intubations as a first attempt airway. 2 of those were successful. and 7 of those 8 were on adults. So what does that mean? If we use the intubation, the endotracheal tube, as the preferred ventilation method, we're successful 25% of the time in those 8 attempts. If you go down to the bottom on the right side, the intubation totals are 16 attempts as a second attempt. That means something else was attempted first, maybe an I-gel or some other sort of airway. Out of those 16 second attempts, 7 of those were successful. Again, less than 50% success rates for endotracheal intubation in 2017 in Johnson County. If you look on the left, it has our I-gel numbers. The I-gel was attempted much more than the endotracheal tube. Out of 346 attempts as a first-line device, 305 were successful. That's over 88% success rate for the I-gel in 2017. Also, you can see most of those attempts were made on adults. Another statistic I find interesting here is the provider level. For 2017, over half of our attempts were attempted by BLS personnel with an 88% success rate. Also, you can see most of those were attempted during cardiac arrest. There were some that were second attempts. As you can see on the bottom, the 38 attempts as the second attempt, 24 of those were successful. So here's a short video that may sum up some of these intubation attempts.
Questions?
Yeah, Turkey's asked me to be his best man. You got any advice?
No, I don't. Not at this moment.
You know what sucks? Everyone keeps talking about how Dr. Casey's helped them, and he doesn't even know I exist.
So introduce yourself.
I haven't seen him all day. He's probably off trying to help figure out some procedure that's going to save humanity.
Why can't I sit on you?
Why?
Probably.
Newbie, it turns out I do have some best man advice. Go easy on the mascara in case you cry during your toast, and if you're going to chase after the bouquet with all of the other girls, make sure you kick off your pumps so you don't snap one of those chicken ankles of yours.
Thanks for coming back.
Barbie, are you sure you went into his lungs?
Because it looks like you're blowing up his stomach.
Oh, damn it, his O2 sat's dropping. Get out of the way, honey, come on.
Even if you've done a procedure 5,000 times, there's no guarantee you won't screw up number 5001.
A few more seconds, we've been coding this guy. Take that. Barbie, as hard as it is to remember, but air goes in the lungs.
So do we have better options? When it comes to endotracheal intubation, will we ever get there? Will we ever get to the Eureka point? What are the alternatives? One alternative we found is the I-gel. We used to have the combo tube. Are there other alternatives that we haven't looked into yet? Alternatives that the hospitals use, such as the video intubation, may be something that is possible to improve our intubation statistics in the future. So who says those are better? Who decides whether the I-gel is better than the endotracheal tube? As you can see in our 2017 statistics, I think the numbers speak for themselves to tell our medical director which one we are better at. So how do we get better? Do we need more practice? Is it a skill that we just don't use? Is that why we have a 25% success rate? What would make us better at endotracheal intubation? As you all know, in Skills and Sim, we do a lot of practice on CPR. However, if you look at our numbers for CPR, they're among the best in the country. So is that the method that we need to use for intubations or for ventilation as well? The more we do it, the better we'll get. Or do we just need more practice? I found a video online that shows one way that we could brush up on our intubation skills, although I don't necessarily recommend this particular technique. Kids, don't try this at home.
Needle goes in. We just sit there for a minute, and well, 2 seconds. He'll withdraw bubbles slowly. And then just get the 3 cc's in and pull out. Perfect. Yeah, because you want to spread it around the trachea. The next thing we're going to do is I have 5 more cc's of lidocaine, and this will go on the fibroscope. And this way we can spray structures as we see them. Okay, so we saw the cords and sprayed them. And we'll get started again.
Like I said, that's one way to brush up on our intubation skills, but I don't recommend that technique. So, what do we strive to become? A technician or a clinician? The technician, as you can see defined on the left side, is the person that does the skill. The clinician, on the right side, is the person that does the skill with an overall goal to managing the patient and not necessarily intubating, but ventilating the patient. So why are we so passionate about the endotracheal tube? Is it because that's the way we've always done it? It's our status quo. This is what I learned in school. This is what I was told was best back in the day. Is that why we're so passionate? Do we have proof that it's better? Are we passionate about it because when we arrive to the emergency room physician immediately removes the eye gel and places an endotracheal tube? Is it best for the patient? Is that what's best? If we intubate the patient to begin with and secure the airway, they can be transferred to the vent sooner than having to replace that tube in the emergency room. So one workshop that brings this concept in full circle would be a thing called Who Moved My Cheese? It's a book and a workshop that is designed to discuss change. I highly recommend it. If you haven't heard of it, take a look at it. I think you'd enjoy it. So again, ventilation is more important than intubation, and we should strive for the clinician to ventilate our patients. In conclusion, the MEDAC protocol is based on research. I like to think we do the right things for the right reasons. One example is our immobilization. The research shows that what we were doing wasn't necessarily best for the patient, therefore we changed. Is that where we're at with intubation? Or do we just need to change our training? This starts with the EMS Physicians Committee. They define the standard of care for Johnson County ALS providers and have looked into ventilation versus intubation. So again, numbers speak louder than words. Are we proficient? How do we get there? I look forward to any questions, concerns, or comments you have regarding this topic. Feel free to contact myself or any of the other education staff here at Johnson County MedAct or with your local fire department. I hope you have a good day. Thanks for listening.